So when I consider various therapies for pneumonia patients, particularly macrolides, what we think are the advantages, and what I consider the advantages, are that they are well known, they are tolerable, they're inexpensive. One of the major disadvantages of the macrolides, however, are the resistance rates, which are continually growing, perhaps for a variety of reasons, but most likely from over-prescribing.
It's kind of difficult in primary care because I don't think we really know what the level of resistance is. And so we're prescribing as we normally prescribe without necessarily even knowing about the resistance in the community. It's interesting because when many of us practiced in hospitals, we would get an idea of what was happening in terms of antibiotic resistance in that environment. Yet now in practice, in the sort of outpatient setting, we don't really have a sense of how frequent the resistance is.
You know, I know our hospital does track strep pneumococci, but there are a lot of institutions now that don't have it on the panel anymore. I guess the general assumption that they don't need to look at susceptibility patterns, and I think it would be a wide awakening to many places if they were to monitor this very closely. They'd be pretty shocked, I think, as most of us are, knowing that rates now exceed 50% for macrolides and strep pneumococci. I think in terms of treating community-acquired pneumonia, why clinicians in the community may fail to recognize failure, there are often, patients often seek, their primary care physicians out, but they also are treated in urgent care settings, for example, and clinicians may not have the opportunity to follow up with their patients because they're seen on a kind of an emergency basis or an urgent basis.
A lot of these things they're treating are viral infections that didn't need antibiotics. They weren't pneumonia, they were bronchitis or something, and these people were getting better. So their perception is, it's not a big deal. I see pneumonia I saw 8 cases yesterday. They were all fine.
Historically, there's been a knee-jerk reaction to use azithromycin as a first-line drug. It does have some side effects, and it does. And one of the biggest ones from a microbiology point of view is the selection of resistance. It selects for resistance a lot faster than even the other macrolides. So why is it used so much? It's easy to use. It's a 5-day therapy, and it's sort of a go-to therapy when you don't know what's wrong.
So physicians are very comfortable with the macrolides that are there, like azithromycin. They've used it for years. They're very comfortable with quinolones, like levofloxacin. They've used it for years. I think you've got to educate them that pneumonia is a serious problem, that there's increasing resistance, especially with the macrolides, and that you don't want to overuse the quinolones.
And patients with severe pneumonia, very clearly that group, if they have a resistant organism, they're going to have an increased likelihood of failure and increased mortality if we don't get them on the appropriate antibiotics. I don't believe that physicians really appreciate the mortality from pneumonia. It's common, and it's the leading cause of infectious death in adults. But because it is so common, we really don't think of the mortality as being as high as it really is. In the emergency department, we will tend to see more of the sicker patients and have a little better appreciation for individuals, the risk of their death. And I will tell you, just in the past year, I've seen several patients that have come in, some young, very, very ill, and which they have died as a result of community-acquired pneumonia. So for some of us, it is real.